dear students, I am Dr. Pratyusha. In this video, let us learn about acoustic neuroma, also known as vestibular schwannoma. It is one of the most important topics in ENT. In almost every exam, a question is asked about acoustic neuroma. Let us learn everything about it in detail. Acoustic neuroma, also known as vestibular schwannoma. What exactly is this acoustic neuroma? As the name suggests, oma means tumor. This is a tumor. It is a benign, encapsulated, extremely slow growing, tumor of the cerebellopontine angle. From where is it arising? From the cerebellopontine angle. And also it is a tumor of 8th cranial nerve, of the vestibulocochlear nerve. So the most important points over here are 8th cranial nerve and cerebellopontine angle. Before we study any further about acoustic neuroma, we need to understand about two basic things, and they are about the 8th cranial nerve and about the cerebellopontine angle. The 8th cranial nerve emerges from the lateral aspect of pontomedullary junction. Let me write that down for you. It emerges from lateral aspect of pontomedullary junction. After it emerges from that area, it goes forward into the cerebellopontine angle. Further on, it divides into vestibular nerve and cochlear nerve and then enters the internal acoustic meatus. Internal acoustic meatus is also called as internal auditory canal. We have the external auditory canal in the external ear and this internal acoustic meatus or internal auditory canal beyond the inner ear. This is where this 8th cranial nerve is traversing. And it is not traversing alone. There are 4 other components. This is how the structure of internal acoustic meatus would look like. I'll show you a picture for better understanding. This is the cross section of internal acoustic meatus. It is divided into a superior and an inferior chamber by something called as falciform crest. Now the superior chamber is again divided into 2 compartments by a very important structure which is known as Bill's bar. This division in between is called as Bill's bar. Inferiorly also we have 2 compartments, but there is no specific name. Now let me tell you where all which structure passes by. This is the superior, this is the inferior compartment, this is anterior and this is posterior. Now let us see where which structure is going. Antero-superiorly is the 7th cranial nerve. The facial nerve is also traversing in the internal acoustic meatus. How do you remember this? Now face is present anteriorly and it is also the most superior part of the entire human body. So you can remember that the facial nerve, which supplies the sensory supply to the face, is present anterosuperiorly in the internal acoustic meatus. Below it, on the anterior aspect itself, we have the cochlear nerve. I told you the vestibulocochlear nerve has already divided into vestibular nerve and cochlear nerve before entering the internal acoustic meatus itself. Now the cochlear nerve is passing antero-inferiorly. Ears are slightly low. But when somebody is speaking to you, would you want the person to be placed in front of you or behind you? It's more comfortable if the person is anterior to us, isn't it? The cochlear nerve is also anterior. Now coming to the posterior compartments, superior and inferior, what else is left? The vestibular nerve. This vestibular nerve is divided into superior vestibular nerve and inferior vestibular nerve, and this is very simple. The superior vestibular nerve is in the superior compartment and inferior vestibular nerve is present in the inferior compartment. This is for you to memorize what I just told you about how structures are placed. There is absolutely no logic to this. This is how structures are placed, and this is to help you learn them. Let me quickly revise. Anterosuperiorly facial nerve, antero-inferiorly cochlear nerve, posterior-superiorly superior vestibular nerve, posterior-inferiorly inferior vestibular nerve. This is the arrangement of structures in the internal acoustic meatus. With this understanding, let us now move on to the next one, that is the cerebellopontine angle. You must also learn about cerebellopontine angle. The picture that you are seeing here is of acoustic neuroma that is present in the cerebellopontine angle. Now please understand that this is the cerebellopontine angle. It is actually a shallow triangular depression in between the cerebellum and the pons and called as cerebellopontine angle. Where exactly is the cerebellopontine angle? This is the cerebellum and the brain stem is coming down like this, and here this triangular depression is called cerebellopontine angle. Now, why is the cerebellopontine angle so important to us? Because there are many vital structures, important nerves that are passing through the cerebellopontine angle. Like, on the superior aspect, we have the 5th cranial nerve, and on the inferior aspect, we have 9, 10 and 11 cranial nerves passing via the cerebellopontine angle, which makes it very important. Can you see the nerves here? If I erase the annotations. This over here is the 5th cranial nerve, and these two are other nerves. Trigeminal nerve is present on the superior aspect. Glossopharyngeal, vagus and accessory nerves are present on the inferior aspects. Now, with this basic understanding of the 8th nerve as well as the cerebellopontine angle, let us go back to our primary topic, that is acoustic neuroma. You will eventually understand why understanding these two structures in such detail is essential. Okay. Let's move back to acoustic neuroma. What is acoustic neuroma again quickly? It's a benign encapsulated, extremely slow growing tumor of the 8th nerve present in cerebellopontine angle. Now please remember that this is the most common tumor in the cerebellopontine angle. It is the most common tumor in the cerebellopontine angle. 80% of all tumors in the cerebellopontine angle are acoustic neuromas. Okay. Let us understand about the origin and growth of acoustic neuroma. Acoustic neuroma originates from Schwann cells. What are Schwann cells? These are the cells that myelinate the neurons of peripheral nervous system. Just like how oligodendrocytes myelinate the neurons of central nervous system, Schwann cells myelinate the neurons of peripheral nervous system. So, acoustic neuroma arises from Schwann cells. Schwann cells of which nerve? Mostly from vestibular nerve, but sometimes also from cochlear nerve. It arises mostly from vestibular nerve. That's why this tumor is also called as vestibular schwannoma. Is this clear? From the Schwann cells also, to be more specific, it arises from a zone called as Obersteiner-Redlich zone. In the process of myelination, we have various zones, and this tumor arises from Obersteiner-Redlich zone. Okay? And Schwann cells in the nerve is present all through. From which part does this arise specifically if somebody asks you? It arises in the internal acoustic meatus. Is this clear? Now the tumor has originated in the internal acoustic meatus from the Schwann cells. Then what happens to it? It expands, grows and erodes the internal acoustic meatus. It grows and erodes the internal acoustic meatus. After the internal acoustic meatus, what is the structure that is present? Yes, it is the cerebellopontine angle. So it erodes the internal acoustic meatus and moves towards the cerebellopontine angle. But this process takes several years for it to progress from the internal acoustic meatus into the cerebellar angle. Repeat. Into the cerebellopontine angle, because it's a very slow growing tumor, as I earlier said. Once in the cerebellopontine angle, its manifestations will begin to show up. The first structure to be affected is the trigeminal nerve. Later on, 9, 10 and 11 cranial nerves are also affected. Then the tumor grows so much so in size that it displaces the brain stem. The brain stem is displaced. And it also begins to exert pressure on the brain stem. And it grows further on beyond that also. And now what happens? It exerts pressure on cerebellum. After that also it continues to grow so much so that now the intracranial tension is increased. Increased intracranial tension. First what happens? The fifth nerve is affected, then 9, 10, 11 nerves, then pressure is exerted on the brainstem and the brainstem is displaced. Then the cerebellum is affected and finally the intracranial tension is increased. All these happen as the size of the tumor grows. Okay. Now acoustic neuroma is classified into various types. And what is the basis for this classification? The size of the tumor is the basis for this classification. So we have 4 categories here. The first stage or first type is intracanalicular. Here, the tumor is confined to the internal acoustic meatus. It is still inside the internal acoustic meatus. It has not eroded the meatus and come outside. Next, the second stage, it is called as small size tumor. Until when is it called small size tumor? As long as it is less than 1.5 centimeters in size. The next one is medium-sized tumor, and a medium-sized tumor is sized anywhere between 1.5 to 4 centimeters. And beyond 4 centimeters, it is called as a large size tumor. After it is more than 4 centimeters. So this is the classification of acoustic neuroma. Before studying clinical features, let us look into the histopathology of acoustic neuroma, which is very important among CNS tumors. Because acoustic neuroma has a very classical appearance. You find two zones. The first zone is called Antony A pattern and the second one is called Antony B pattern. Antony A is the dense area and B is the loose area. There are multiple parallel elongated cells arranged as palisades. So this is how it would look. And there are some special bodies called as Verroquet bodies. These are specific to acoustic neuroma. Let me show you a picture of how this looks. So this is a picture of acoustic neuroma where you can see two types of zones. One is the densely packed area and one is slightly loosely packed cells. Okay. So after histopathology, now let us move on to the clinical features. Before studying about the clinical features, let us look into certain predilections for acoustic neuroma. First is age. Usually between 40 to 60 years. This is the age group that is affected. Second, coming to sex, females are affected more than males. And third, genetic predisposition. % of patients of acoustic neuroma also have neurofibromatosis, von Recklinghausen's disease. So it's only 5%, but what makes this 5% very important to us is difference in prognosis. These 5% patients who have neurofibromatosis along with acoustic neuroma express certain special and unique features that are different from the usual acoustic neuroma. What are they? Now, acoustic neuroma is usually a benign tumor. When coexistent with neurofibromatosis, it becomes aggressive. Okay. That is encapsulated, but this is non-capsulated. There is no capsule. The usual age group is 40 to 60 years, but here sometimes children are also affected. If you see a child with acoustic neuroma, they usually have neurofibromatosis also. And although acoustic neuroma is usually unilateral, it could be bilateral or even multiple lesions are possible in these neurofibromatosis patients. And very rarely it can turn malignant in this group. So this makes this 5% patients very important to us. What are the differences? Usually it is benign. Here it is aggressive. And also very rarely it can become malignant. The usual age group is 40 to 60. Here children could also be affected. There it is unilateral, here it is bilateral and multiple lesions are possible. It is encapsulated and here it is non-capsulated, no capsule in patients with neurofibromatosis. Now let us move on to the actual clinical features. The clinical features depend upon the stage of the tumor and the size of the tumor, where it is present. If the tumor is present in the intracanalicular part, then the patient experiences cochleovestibular symptoms. It is mainly the 8th nerve that is affected here, and symptoms pertaining to that are seen. What happens when the cochlear nerve is affected? It is responsible for hearing. So the patient experiences hearing loss. What type of hearing loss is it? It is unilateral, progressive, sensorineural hearing loss. In sensorineural also, it is retrocochlear type, because the problem is in the 8th nerve. The cochlea is absolutely fine. So it is retrocochlear type of hearing loss. Apart from this, there is tinnitus also, ringing sensation in the ear. And what type of tinnitus is it? It is high pitched and continuous type. So this is about the cochlear symptoms. Coming to the vestibular symptoms, vestibular nerve is responsible for balance. So when that is affected, there is unsteadiness, loss of balance. Is this clear? So when the tumor is in the intracanalicular part, it shows cochlear and vestibular symptoms. Then it will slowly grow and come into the cerebellopontine angle. When it is in the cerebellopontine angle, all the cranial nerves are affected, as I told you earlier. What is the first nerve to get affected? Very important, it's an MCQ also. First nerve to be affected, it is the trigeminal nerve. Fifth cranial nerve. And when the trigeminal nerve is affected, what are the manifestations you see? It supplies the face. So when trigeminal nerve is affected, we see that there is decreased corneal sensitivity. The afferent for corneal reflex goes via trigeminal nerve. Efferent comes via facial nerve. So there is decreased corneal sensitivity. Plus it also supplies sensory supply to the face area. So there is numbness and paresthesia of face. Numbness and paresthesia of face. So when these features are seen, we can assume that the tumor is roughly around 2.5 centimeters in size. Then only it can bulge upon the trigeminal nerve and cause these symptoms. When it is around 2.5 centimeters, that means it is a medium-sized tumor now. After the trigeminal nerve, the next one to be affected is facial nerve. Facial nerve is a mixed nerve. It has sensory as well as motor components. So the sensory is affected before motor. In sensory, the various features that we see are, one very special and important feature, it is hypoesthesia of the posterior wall of external auditory canal. Hypoesthesia of posterior wall of external auditory canal. That area is supplied by facial nerve, and when facial nerve is affected, there is hypoesthesia felt there. This is called as Hitzlsperger sign. What is Hitzlsperger sign? Hypoesthesia of posterior wall of external auditory canal supplied by facial nerve being affected in acoustic neuroma. That is Hitzlsperger sign. It's an important MCQ question, please remember. Other things that are seen are, there is decreased lacrimation. Facial nerve is also responsible for tear glands. So there is decreased lacrimation. And how can you get to know about this? By performing a test called as Skirmer test. Next, there is loss of taste sensation in the anterior 2/3 of tongue. And how can we test this? By doing electrogustometry. After the sensory part, slowly the motor part of facial nerve also gets affected. And how does this manifest? It manifests as delay in blink reflex. For blinking, we need the orbicularis oculi muscle, and that is supplied by facial nerve, motor component of facial nerve. So when that is affected, the blink reflex is delayed. Then after the facial nerve, we have the 9, 10 and 11th cranial nerves being affected slowly. And what do these nerves supply? They supply the palate, pharynx and larynx. So when those muscles, when the palatal, laryngeal and pharyngeal muscles are paralyzed or weakened, it leads to dysphagia and hoarseness of voice. Dysphagia and hoarseness of voice. Then in our order, after the cranial nerves, next what is affected? The tumor grows further in size and now it pushes the brainstem and exerts pressure effect on the brainstem. So when it has grown so much, the features that we see are ataxia, unsteadiness of gait, and weakness and numbness of arms and legs. Weakness and numbness of arms and legs. Why so? Because all the various tracts are passing via the brainstem, and when that is affected, depending upon the area that is affected, you see numbness or weakness in various muscles, either of the upper limb or lower limb. Further on, after the brainstem, the cerebellum gets affected. And when cerebellum gets affected, again we see ataxia. And here we perform certain tests, cerebellar function tests, called as, for example, heel-knee test, finger-nose test, these help in identifying the cerebellar function. For example, in finger-nose test, the patient is asked to touch his nose with his own finger, and if he is not able to accurately do so, it shows that the cerebellum is not functioning properly. Similarly, there is something called as diadochokinesia, where the patient is asked to flap his fingers like that, and if he is unable to do so, it's called as dysdiadochokinesia, which is a symptom of cerebellar dysfunction. Dysdiadochokinesia. So this is about cerebellum. And further on, what happens in the last stage? There is increased intracranial tension. This is the terminal stage. After this, death can occur. So when the intracranial tension is increased, there will be headache, nausea, and vomiting, as well as papilledema. If you do a fundal examination, you can see papilledema. So these are the various clinical features of acoustic neuroma that are seen in various stages of the disease. After clinical features, let us now move on to investigations. How do we investigate a case of acoustic neuroma? The first thing that we perform is audiological tests. When we do audiological tests, what will we find out? As we already know, it is a type of sensorineural hearing loss. What type of sensorineural? Retrocochlear. So all the features pertaining to this will be seen. When you do a pure tone audiometry, we will observe that the sensorineural hearing loss is more marked in higher frequencies. It's more marked in higher frequencies. Next, we do speech audiometry. When you do speech audiometry, you will observe that the speech discrimination score is poor. Speech discrimination score is poor and disproportionate to the pure tone audiometry findings. What do I mean by this? Suppose a person is experiencing 40 decibels hearing loss. We expect the speech discrimination score to be at a certain level. Now in these patients, it is worse than what is expected, poorer than what is expected. So we say it is disproportionate to pure tone audiometry results. And certain other features that you observe are, there is something called as rollover phenomenon, which is a feature of retrocochlear hearing loss. What is rollover phenomenon? As we increase the loudness, the person can hear better. Normally also, even for normal people, if you increase the loudness, we can hear better, isn't it? In these patients also, in patients of hearing loss also, as you increase the loudness, they can hear better and better. But there is a small twist that occurs here. As you increase the loudness, the patient hears better and better up to a certain point. After that, you further increase the loudness, but the patient cannot improve his hearing capacity. In fact, it diminishes. The hearing capacity becomes like this. Until this point, he is also hearing better and better, but after this, it diminishes. Although you have increased the loudness, hearing capacity diminishes. That is called as rollover phenomenon, which is a feature of retrocochlear hearing loss. And this rollover phenomenon is positive in these patients. Okay. And please make a note of this, something called as recruitment phenomenon. What is recruitment phenomenon? It is a feature of cochlear type of hearing loss. You keep on increasing the loudness, the patient cannot hear, so you further increase your loudness, the patient cannot hear, you further increase, and suddenly the patient will say, why are you screaming so loudly? Have you experienced this, especially in senile people? They can't hear and suddenly they start to hear, which is very, very loud, intolerable to them, and they say, why are you screaming so loudly? Until before, they couldn't hear anything and all of a sudden it becomes intolerably loud. That is called as recruitment phenomenon. And that recruitment phenomenon is absent here. Why is it absent? Because this is retrocochlear hearing loss. Recruitment phenomenon is a feature of cochlear type of hearing loss. Okay? Alright. Then we have something called as stapedial reflex decay test. What is the stapedial reflex decay test? What is stapedial reflex? When a very loud sound is presented to the ear, the stapedius muscle contracts to prevent damage to the inner ear structures. That is stapedial reflex. What is stapedial reflex decay? When you continuously present loud sounds, this reflex, this response diminishes because it's a reflex arc and it has some limitations. So if you continuously stimulate it, after some time it decays. that is normal. Stapedial reflex decay is normal. In these patients, there is no decay. There is no decay. It is absent. Why is it so? The loud sound is perceived by the eighth nerve. It goes inside, there is a reflex center, and the efferent arc is via the facial nerve, which supplies the stapedius muscle, and it contracts. When the eighth nerve is affected, when the vestibulocochlear nerve is damaged, this entire reflex pathway is disturbed, so there is no decay. That is one feature observed in acoustic neuroma. Okay. Next, these are the audiological tests. After audiological tests, what we do is neurological examination. In neurological examination, we test for cranial nerves. From 1st nerve to 12th nerve, all cranial nerves are tested with special focus on 5th, 7th, 9th, 10th, 11th cranial nerves because they are affected here. Next, we also do cerebellar function tests. I have already explained you what are the cerebellar function tests. Finger nose test, heel knee test, dysdiadochokinesia, all of them are done. Okay. Then, vestibular tests are done. In vestibular tests, the caloric test is usually positive. Then, BERA is also done as a part of audiological investigations, brainstem evoked response assessment. In BERA, as you know, it is the 5th wave which is most significant. So, more than 0.2 millisecond difference between both ears is significant. Is it clear to you? The 5th wave of BERA, if there is more than 0.2 milliseconds difference between both the ears, it is considered to be significant and we cannot ignore that. We have to investigate further. After this, we can do radiological investigations. What are the various radiological investigations that are done? First one, we start from the basic, an X-ray. You can see acoustic neuroma on an X-ray also. Next, we do a CT scan. CT has more sensitivity. In a CT, you can visualize a tumor that is 0.5 centimeters in the posterior cranial fossa. A tumor that is as small as 0.5 centimeters can also be diagnosed in CT, but 0.5 centimeters in the posterior cranial fossa. If it is in the intracanalicular part, we cannot see it on CT. If it has come out into the posterior cranial fossa, then it can be visualized on a CT scan. Then the next one we have is MRI. Highly sensitive. In MRI also what we use is a gadolinium contrast enhanced MRI. This is considered to be gold standard in the diagnosis of acoustic neuroma. It can diagnose any tumor as small as possible, even in the intracanalicular part. Okay. And finally, we do vertebral angiography. Why is a vertebral angiography done? Now, in cerebellopontine angle, although acoustic neuroma is the most common tumor, it's also possible that some other tumors are present. To exactly diagnose acoustic neuroma, we need to do a vertebral angiography. Some cysts could be present, metastasis could be there, or some other tumors in that area could be present. So for that purpose, we have to do a vertebral angiography. Now on MRI of acoustic neuroma, you see a very classical and important appearance. I'll show you the picture and then you can answer it. So this is an MRI image of acoustic neuroma. What I'm annotating now is the tumor. This is called as the classic ice cream cone appearance. Ice cream cone appearance of acoustic neuroma on an MRI. This is how it looks. This is the ice cream cone appearance. Okay. Now let us move on to the treatment of acoustic neuroma. It is a tumor and it has to be removed, surgically resected, as simple as that. Surgical removal of tumor. Now there are various approaches to remove the tumor, and that depends upon the stage and the size of the tumor. Okay. So in case a surgery is not possible, if the patient is unfit for surgery or there are some other contraindications, then what we do is gamma knife or a cyber knife is used and the tumor cells are destroyed. This is the alternative therapy. So this is all about acoustic neuroma. Let me quickly revise this entire topic for you very briefly. It's a very important topic. So acoustic neuroma is also called as vestibular schwannoma. It's also called neurilemoma, or it's called tumor of the 8th nerve. Okay, it is a benign, encapsulated, extremely slow growing tumor of cerebellopontine angle of the 8th cranial nerve. You know about the anatomy of 8th nerve. It emerges from the lateral aspect of pontomedullary junction, then it goes into the cerebellopontine angle and then into the internal acoustic meatus. In the internal acoustic meatus, you have 4 chambers. Horizontally, they are divided by falciform crest, and the superior chamber is again divided into anterior and posterior by Bill's bar. Okay, so we have facial nerve, cochlear nerve, superior and inferior vestibular nerves. Coming to the cerebellopontine angle, it's a shallow triangular depression between the cerebellum and pons, but that's important because vital structures are passing in that area. Superiorly, we have the trigeminal nerve, and inferiorly, we have 9, 10 and 11 cranial nerves. Okay, so acoustic neuroma is the most common tumor in the cerebellopontine angle. Coming to its origin and growth, it originates from Schwann cells, mostly from the vestibular nerve and from a zone called as Obersteiner-Redlich zone. Okay. And from the internal acoustic meatus, it grows, expands and erodes the internal acoustic meatus to come into the cerebellopontine angle, and from the cerebellopontine angle, it further grows and displaces the brainstem, and then it goes into the cerebellum and finally increases the intracranial tension, that is the terminal stage. The classification is based on the size, intracanalicular, small size, medium size and large size. And in histopathology, what you have to remember is Verroque bodies and Antony A and Antony B zones. Clinical features, the predilections are 40 to 60-year-old female, and 5% of patients have a genetic history of neurofibromatosis. And that is important because those people exhibit some special features such as aggressive, non-capsulated, could be seen in children also, could be bilateral or with multiple lesions, and it could very rarely turn malignant. Now coming to the clinical features, when it is in the intracanalicular part, the cochlear nerve is affected, resulting in sensorineural type of hearing loss, retrocochlear type of sensorineural hearing loss, along with a continuous and high-pitched tinnitus. It is unilateral and progressive. And the vestibular symptoms are loss of balance and unsteadiness. When it is in the cerebellopontine angle, the first nerve to be affected is the trigeminal nerve. What you see is decreased corneal sensitivity, numbness and paresthesia of the face, and you can assume that the tumor is approximately 2.5 centimeters when it is showing these features. Then the facial nerve is affected. What is Hitzelberger sign? Hypoesthesia of posterior wall of external auditory canal. And then decreased lacrimation by Schirmer test, loss of taste sensation in the anterior 2/3 of tongue, which can be checked by electrogustometry. And then after sensory part, even the motor part of facial nerve is affected, and that's when you see a delay in blink reflex. And then slowly 9, 10, 11 cranial nerves are affected. That's when you see dysphagia and hoarseness of voice. Why do you see them? Because the muscles of palate, pharynx and larynx are affected. When it goes on to the brainstem, then you observe ataxia. Depending upon the tract that is involved, there is weakness and numbness of arms and legs, and also unsteadiness of gait. When it's in the cerebellum, again ataxia is observed, and you do these various cerebellar function tests. And finally, when the intracranial tension is increased, the patient experiences headache, nausea, vomiting, and papal edema can be seen on fundoscopy. Okay. Next, coming to the investigations, first we do audiological tests. It's a retrocochlear type of hearing loss. Now, when you find a patient with unilateral progressive retrocochlear type of hearing loss, the diagnosis of acoustic neuroma has to come into your mind. Now, acoustic neuroma is a very slow growing tumor. So, if you can catch hold of it in the intracanalicular part itself, that's going to be very, very beneficial to the patient. And that is what makes this examination important topic clinically relevant to you. If you can diagnose the case when the tumor is in the intracanalicular part itself, the prognosis is going to be very, very different and beneficial for the patient. Okay. The speech discrimination score is poor, disproportionate to the pure tone audiometry results, and rollover phenomenon is positive, recruitment is absent. Stapedial reflex decay shows no decay, the decay is absent. Neurological examination, you have to examine the cranial nerves and do cerebellar function tests. If you do vestibular tests, the caloric test is positive. Why? Because the vestibular nerve is also affected very much early in the course of the disease. And the most important wave of Bera is the 5th wave, and a difference of more than 0.2 milliseconds is significant. Coming to the radiological tests, X-ray, CT, MRI, and finally vertebral angiography. What is most important is the ice cream cone appearance that is seen on MRI, which is the gold standard investigation for acoustic neuroma. Coming to the treatment, surgical removal of the tumor is the mainstay of treatment. In case surgery is not possible, you can use a gamma knife or a cyber knife to destroy the tumor cells. So this is all about acoustic neuroma. I hope you have understood it clearly. Thank you very much and have a nice day.